Constipation in emergency department. What is constipation? Constipation is the infrequent, difficult, or incomplete passage of stools. A patient is generally considered constipated if they have fewer than 3 bowels movement per week, hard stools, excessive straining, feeling of incomplete evacuation, need for manual assistance to pass stool. In emergency department, the most important question is whether it is simple constipation or a life-threatening surgical condition. Emergency approach A, B, C, D, E. Airway, ensure airway is patent. B, breathing, check respiratory rate, oxygen saturation. C, circulation, pulse, blood pressure, IV access if dehydrated. Give IV fluids if needed. Disability, assess the mental status, look for confusion, especially elderly. E, exposure, abdominal distension, look for distension, surgical scars or hernias. History, ask present illness. When was the last bowel pass movement? Last passage of lattice. Stool consistency. Abdominal pain. Vomiting. Blood per rectum. Fever. Weight loss. Red flag signs. Severe abdominal pain. Persistent vomiting. Fever. Blood in stool. Weight loss. No flatus. Abdominal distension. These suggest obstruction or another serious condition. Past history. Previous abdominal surgery. Is there any previous abdominal surgery? Colon cancer, hypothyroidism, diabetes, neurological disease, Parkinson disease, and stroke. Drug history. Common causes opioids, iron tablets, calcium supplements, anticholinergics, triglyceride antidepressants, calcium channel blockers that are verapamil. Examination. On general examination, patient will look like dehydrated, pallor, cachexia, fever. On abdomen, on inspection, there will be distension, surgical scars, hernias. On auscultation, high-pitched bowel sounds, which will be obstruction. Absent bowel sounds, that is ileus. Palpation, there will be tenderness, guarding, masses, fecal loading. Percussion, tympani gases, dullness, feces. DRE, very important in the ear, look for hard stools in the rectum, fecal impaction, blood, tumor, anal fissure, hemorrhoids, and rectal tone. Red flags requiring immediate attention. Think of intestinal obstruction, bowel perforation, toxic megacolon, ischemic bowel, volvulus, colon cancer. What will be the differential diagnosis till that? The differential diagnosis will include simple constipation, fecal impaction, large bowel obstruction, small bowel obstruction, ileus, colorectal cancer, hypothyroidism, hypercalcemia, Parkinson disease, spinal cord lesion, Hirschsprung disease. Investigations. Blood test will be sent includes CBC for infection anemia, urea crete, electrolytes, calcium magnesium blood glucose, thyroid function tests, CRP, lactate. Imaging. Abdominal X-ray, erect and supine, useful for fecal loading, dilated bowel loops, obstruction, perforation. CT abdomen with contrast. Indications. Suspected obstruction, severe abdominal pain, peritonitis, suspected cancer, ischemia, perforation, uncertain diagnosis. Other investigation. Stool occult blood, selected patients. Colonoscopy, not usually performed in the ER. Arrange later if indicated. Emergency management. Management depends on the cause. Simple constipation. So for this, hydration. Encourage oral fluids. IV normal saline if dehydrated. Lifestyle advice. High fiber diet. Fruit and vegetables. Exercise. Regular toilet habits. Number second, medications. Bulk forming includes psyllium. Osmotic includes lactose. lactulose, polyethylene glycol. Stimulant includes senna, bisacodyl. Stool softener includes decossate sodium. Rectal therapy. If stool is impacted, glycerine suppositories, bisacodyl suppositories, phosphate enema, warm saline enema. 4. Manual disimpaction. If indication hard stools palpable in the rectum, enema unsuccessful, severe fecal impaction. Use lubricant and adequate analgesia if required. If intestinal obstruction is suspected, do not give laxative or enema until obstruction has been excluded. Management, keep patient NPO, nil by mouth, IV fluids, correct the electrolyte abnormalities, nasogastric tube if significant vomiting or obstruction, adequate analgesia, antiemetics, urgent surgical consultation, CT abdomen. What is admission criteria? Admit patient with bowel obstruction, peritonitis, fecal infection, requiring repeated interventions, severe dehydration, electrolyte disturbances or sepsis, elderly or frail patients unable to manage at home. Discharge criteria. Patients may be discharged if they have simple constipation, are hemodynamically stable, have no red flags, can tolerate oral intake, have a bowel regimen and clear follow-up instructions. MRChem or FCPS pulse. Always perform digital rectal examination unless contraindicated. In elderly patient with constipation and abdominal distension, exclude the bowel obstruction first. New onset constipation with weight loss, rectal bleeding or iron deficiency, anemia should raise concern for colorectal cancer. Avoid phosphate enemas in patients with advanced kidney disease because they can cause dangerous phosphate accumulation and electrolyte disturbances. Chronic constipation plus abdominal pain that improves after the defecation suggests irritable bowel syndrome rather than an acute surgical abdomen. This structured approach, ABCDE focused history, abdominal and digital rectal examination, target investigations, cause specific management, is a standard emergency medicine approach to a patient presenting with constipation. Thank you.